Good evening, everybody. It is a great pleasure to be with you in one of the educative EAVA nights. And it is also a very elegant program, which is designed by my dear colleague, Professor Ahmed Shawqi. And it is sponsored and powered by Novartis. And of course, it is one of the activities of the Egyptian Association of Vascular Biology and Atherosclerosis. Today, we have a very interesting night. We have very elegant speakers. We have a very valuable and practical data, which is needed in our everyday practice. Our topic today is about the heart failure with preserved ejection fraction. As you all know that the heart failure with preserved ejection fraction is a very tricky problem. The diagnosis is very problematic, needs a lot of algorithms because there is no yet clear evidences about the accurate diagnosis and also the accurate management for heart failure with preserved ejection fraction. But in the latest year, there is a lot of algorithms also, which is very valuable for diagnosing the heart failure with preserved ejection fraction. This night, we have our dear Professor Nabil Farag, who will present to us a very important topic as regard the heart failure with preserved ejection fraction, which is the evidence behind the management of heart failure with preserved ejection fraction, the heart failure or HFpEF trials. I think Dr. Nabil Farag prepared to us a very elegant presentation as usual, and we are all eager to hear from him this topic this night. Please, Professor Nabil.
Thank you very much, Dr. Said, for the introduction. And I would like to thank you also for the great organization. You are doing a lot of effort in everything, Dr. Said, and Dr. Ahmed Shawqi for this very nice lectures and organizations. This is my presentation today. I'm going to talk about the trials addressing heart failure with preserved ejection fraction. All of us are aware of the most of the trials addressing heart failure with reduced ejection fraction. And most of us know the results of these trials and know that these trials shaped the guidelines. And now we have a specific algorithm and a specific pathway for the management of heart failure with reduced ejection fraction. As regard heart failure with preserved ejection fraction, till now we don't have this algorithm and we don't have a clear pathway for the management of such patients. And actually, this is the evolution of heart failure management, starting in 1987 with the first ACE inhibitors, enalapril, that introduced in a very famous randomized controlled trials called the consensus heart failure trials. And the use of enalapril in a patient with heart failure with reduced ejection fraction reduced mortality by about 18%. And this was a very successful in the reduction of morbidity and mortality in heart failure with reduced ejection fraction as compared to placebo. And in 1996, this is the first trial addressing beta blocker use in a heart failure patients with reduced ejection fraction using carvedilol. And this trial also reduced the mortality by about 30% or more than 30%. And this was another success in the management of heart failure patients with reduced ejection fraction. Then in 1999, this was the first introduction of the mineralocorticoid receptor antagonist, Spironolactone. In a famous trial, all of us know these trials, is Lars trial. And again, this trial, Spironolactone was successful in reducing both mortality and morbidity in patients with severe heart failure or with heart failure with reduced ejection fraction. And in 2001, this was the first introduction of the angiotensin receptor blocker, the valsartan, in a famous trial called the VAL-HF trial, and valsartan was able to reduce mortality in such patients by about 16%. Yes, these are very good trials. This is shaped our way of management of a heart failure patients with reduced ejection fraction. And all of these trials actually were addressing or were using the drugs that addressing the pathophysiology of heart failure. The main pathophysiologic mechanisms that aggravates the heart failure were the sympathetic nervous system activation and the renin-angiotensin-aldosterone system activation. And if we compare the norepinephrine level in the plasma in normal subjects as compared to those with a heart failure with reduced ejection fraction, they found that a marked elevation in the norepinephrine in the plasma of those with chronic heart failure with reduced ejection fraction. And this norepinephrine was very injurious to the myocardium, as well as it causes peripheral vasoconstrictions that increase the afterload, and this will make a heart failure more worse and will enter in a vicious circle of a heart failure. As regards the renin-angiotensin system activation also, they found that the plasma renin activity was markedly increased in patients with heart failure with reduced ejection fraction as compared to normal patients. And these were the main neurohormonal systems that are activated by the heart failure. And these are the main neurohormonal systems that are blocked by the new drugs at that time. The ACE inhibitor, the Arps, blocking the renin-aldosterone angiotensin system and the sympathetic nervous system. We have a lot of trials. We have the consensus, as we mentioned before, using enalapril in a heart failure patient with reduced ejection fraction. We have SOLVE trial also using enalapril. We have SAVE trial using captopril in post-myocardial infarction patients. We have the RALS trial using spironolactone, mineralocorticoid receptor antagonist. We have the CBIS and MERIT trial using beta blockers, in CBIS using bisoprolol, and in MERIT heart failure using the metoprolol, and the VAL-HF using valsartan, CHARM trial using the candesartan, EPHESUS trial using eplerenone in post-myocardial infarction patients, and we have the EMPHASIS trial using the same eplerenone in a heart failure patient with reduced ejection fraction. All of this, as we see it now, that mineralocorticoid receptor antagonists, beta blockers, Arps, ACE inhibitors will able to reduce morbidity and mortality in a heart failure patients with reduced ejection fraction. Actually, after all of these trials, we have the guidelines, we have the pathways, we have different algorithms in the management of heart failure patients, and usually we follow these algorithms in the management of our patients presenting with heart failure. And as we see here that ACE inhibitors will able to reduce mortality by 16% in SOLVE trial using enalapril, the ARB in CHARM trial using candesartan, in CHARM alternative, was able to reduce mortality by 17%. Beta blocker bisoprolol in SAPS-2 trial was able to reduce mortality by 34%, and mineralocorticoid receptor antagonists, spironolactone, was able to reduce mortality by 30% in the RALS trial. All of these are very good, but what we have, still we have 50% of patients with heart failure die within 5 years of diagnosis, and 51% experienced cardiovascular death as their primary event was no history of heart failure hospitalization, and sudden death can occur without worsening of symptoms in a 40% of patients with heart failure. And with the exception of lung cancer, mortality in patients with heart failure exceeds that of many cancers. Actually, it's true. And in developed countries, heart failure is a primary cause of hospitalization in patients aged 65 years or more. And this is the vicious circle of heart failure. The patients, with every admission, there is a reduction in the ejection fraction and worsening of the heart failure. And this will end up with the death of the patients with repeated hospital admission. And repeated hospital admission is one of the characteristics of heart failure patients. And 44% of patients with heart failure with reduced ejection fraction will be re-hospitalized at least once. As regards the quality of life, when we're asking our patients about the quality of life, they found that 76% of patients struggle to perform their daily activities, the normal activities. And 63% of patients reported symptoms that are consistent with depression because of not able to do the usual activities they have or they used to do. And 40% of patients struggle to socialize or engage in daily routine activities with friends or family. Back to these trials. With these trials, all of these trials, and with all of these drugs, do you think that we are succeeded in the prevention of mortality and morbidity in patients with heart failure with reduced ejection fraction? The answer is not. We still not able to prevent. We reduce mortality, we reduce morbidity, but we up till now we are not able to prevent these complications of morbidity and mortality. That's why new therapies are needed that can more fully address factors responsible for this. And we have in 2014 the Paradigm Heart Failure Study using angiotensin neprilysin inhibitor. And this was able to reduce mortality by 20% more, or added on the 18% reduced by enalapril. And this slide shows the difference between the renin-angiotensin-aldosterone system inhibitors versus ARNI, or the angiotensin receptor neprilysin inhibitors. We can see that with the angiotensin receptor blockers, we are able to reduce mortality by 15%. With ACE inhibitors, we reduce mortality by 18%. With ARNI, we were able to reduce mortality by 20% as compared with enalapril ACE. So with this drug, the total rate of mortality reduction is 38%. Yes, this is also very good that we are now able to reduce more and more morbidity and mortality, but up till now, we are not able to prevent these complications. So our subject today, this is the most important point I'm going to discuss. We know that heart failure with reduced ejection fraction, we have all of these trials and all of this modification of treatment, and with the introduction of new drugs that help us in the proper management of our patients with heart failure with reduced ejection fraction. What about heart failure with preserved ejection fraction? Number one, I would like to concentrate that, and you have to know that patients presenting with a heart failure with reduced ejection fraction or heart failure with preserved ejection fraction have the same symptoms and signs. So by symptoms and signs, you cannot differentiate between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. That's why heart failure with preserved ejection fraction have the same symptoms and signs of that of heart failure with reduced ejection fraction. And a very important point I would like to concentrate on also that, do you know that the prevalence of heart failure with preserved ejection fraction is about 50% of patients presenting with symptoms and signs of heart failure to the ER? Not only that, but also expected by this year, 2020, that 65% of heart failure hospitalization will be attributed to heart failure with preserved ejection fraction. So even it is more important than that with heart failure with reduced ejection fraction. And heart failure with preserved ejection fraction, actually, it's still a major public health problem. And if we compare between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction as regard the improvement in the outcomes, in the clinical trials and in the guidelines. And if we look at this figure, we can see that with these trials and with the introduction of these new drugs, we can find that there is improvement in survival in patients with heart failure with reduced ejection fraction, with the introduction of ACE inhibitors, with the introduction of beta blockers, with the introduction of mineralocorticoid receptor antagonists, and recently with the introduction of the neprilysin, of the angiotensin receptor neprilysin inhibitor ARNI. What about the outcomes in patients with heart failure with preserved ejection fraction, which is now 50% of patients presenting with heart failure symptoms and signs, and expected to be more than 50%, up to 65%. The outcomes, no improvement in all of the clinical trials. That's why we don't have a clinical pathway or a clear guidelines as regard management of heart failure patients with preserved ejection fraction. That's why they call it, we still have a major public health problem in a patient presenting with heart failure with preserved ejection fraction. Let's go rapidly through all trials addressing heart failure with preserved ejection fraction. And this is the famous 4 trials, outcome trial in a heart failure with preserved ejection fraction, starting with the CHARM trial. And actually, this is a CHARM program because CHARM program included 3 arms. Arms that use the candesartan add on the standard of treatment of heart failure patients, and the other arm in heart failure patients with reduced ejection fraction, and the other arm used candesartan as replacement of ACE inhibitors in heart failure with reduced ejection fraction. And this arm was called alternative. The first arm is called added. The second arm is alternative, and the third arm in a patient with heart failure with preserved ejection fraction. And the results of using the angiotensin receptor blocker candesartan in a heart failure patient with preserved ejection fraction, actually the p-value was a borderline significant in favor of use of candesartan as compared to placebo. Let's go to the second trial using another angiotensin receptor, another ARP, the prentoprel in patients with heart failure with preserved ejection fraction. And if we look to the curves, actually there is no difference at all between those who received prentoprel and those who received placebo. So prentoprel was not successful in the reduction in the outcomes as regard morbidity and mortality in a patient with heart failure with preserved ejection fraction. And in iPreserve, using the irbesartan, the same as in the prentoprel heart failure study. And in a TopCat study using spironolactone, the overall results, there is a mild difference between placebo and those who use spironolactone. And let's go to this trial, the TopCat study as regards the primary outcome, cardiovascular death, heart failure hospitalization, or resuscitated cardiac arrest in patient with heart failure with preserved ejection fraction. Actually, there was no significant difference between both groups, but there was trends towards the reduction of these primary endpoints in the patients who use spironolactone as compared to placebo. But the p-value was not statistically significant. And when they classified these patients by region, for example, those in US, in Canada, in Argentina, and Brazil, actually, the patient who received spironolactone, they had better outcome than those of placebo. This by region. In other regions like Russia and Georgia, there was no significant difference at all between those who received spironolactone and placebo. So still, we have these conflicting results with all of these drugs, Arps, mineralocorticoid receptor antagonists, in the management of heart failure patients with preserved ejection fraction. That's why we have this rationale, still we have this rationale. And as we said before, that heart failure with preserved ejection fraction accounts for half of heart failure, and it is rising in prevalence and is associated with substantial morbidity and mortality. We mentioned that before, that half of the patients presenting with symptoms and signs of heart failure will have heart failure with preserved ejection fraction. Not only that, but also expected this year that patient presenting with symptoms and signs of heart failure will be more with heart failure with preserved ejection fraction. Number two, while the evidence-based therapies exist for heart failure with reduced ejection fraction, as we said before, we have a clear management. We have a clear pathway. We have clear algorithm for the management of such patients with reduced ejection fraction. But for patients with preserved ejection fraction, no therapies, no pathways, no algorithms, no guidelines are clear for the management of such patients. And in the paradigm heart failure, the angiotensin receptor neprilysin inhibitor, sacubitril valsartan, reduce heart failure hospitalization and cardiovascular deaths compared with enalapril in patients with heart failure with reduced ejection fraction, and this an add-on benefit in the management of heart failure with reduced ejection fraction. The last point is in a phase 2 trial, we'll discuss this later, in a heart failure with preserved ejection fraction, sacubitril valsartan reduced N-terminal pro-BNP, improved left atrial size, and NIHA functional class weight compared with valsartan. And actually, these are the main 3 trials addressing the use of sacubitril valsartan in patients with heart failure with preserved ejection fraction. We have the Paramount and we have the Paragon heart failure studies. Let's go to the first trial, which is a Paramount trial, which included about 300 patients, 40 years age or more, with stable chronic heart failure, with signs and symptoms of heart failure, but their ejection fraction is 45% or more. I would like to stress on this point because 45 till 50 is considered a mid-range heart failure patients. More than 50 is a heart failure patient with preserved ejection fraction, and we'll discuss this later on. And also they measured the plasma N-terminal pro-BNP in these patients who received this important drug as compared to the valsartan. This is the design of the study. After running period, discontinuation of ACE and Arps, patients were randomized into 2 groups. The first group received the ARNI in up-titrating dose, starting by 50 milligram twice daily, up-titrated to 100 milligram twice daily, then 200 milligram twice daily. And the second arm included patients who received valsartan, again in an up-titrating dose, starting by 40 milligram twice daily, then 80 milligram twice daily, then 160 milligram twice daily. The duration of this study was 12 years, but actually this study extended till was 12 weeks, and this study extended to 36 weeks, and we'll show the results of this study later on. The primary endpoint was the reduction in the N-terminal pro-BNP from baseline till 12 weeks, and the secondary endpoints is the measurements of the diastolic function by echocardiography as regard left atrial size, which is an indirect evidence of LV diastolic dysfunction, left ventricular size and function, and pulmonary artery systolic pressure. The secondary endpoint was the heart failure symptoms, the clinical composite assessment, and quality of life using the Kansas City Cardiomyopathy Questionnaire. And lastly, safety and tolerability of these drugs. I would like to concentrate that N-terminal pro-BNP, the level of this important neurohormone is directly related to the degree of myocardial injury and the degree of heart failure. So if we have more elevation of N-terminal proBNP, we have more and more injury of the myocardium. And if we have less level of this N-terminal proBNP, this will have less injury to the myocardium and improvement in LV function. So N-terminal proBNP indirectly assess the improvement in left ventricular function. In this trial, with this important point, the N-terminal proBNP, the left atrial size assessment by echocardiography and improvement in NIHA class. As regard N-terminal proBNP, there was a significant reduction in this neurohormone in the patients who received ARNI or received the sacubitril valsartan combination as compared to valsartan. Second, there is a significant reduction in the left atrial volume and left atrial size as measured by echocardiography, and this is an indirect evidence of improvement of left ventricular diastolic function in patients with heart failure with preserved ejection fraction. All of this in patients who received sacubitril valsartan as compared to those who received valsartan only. And by week 12, we can notice that there is improvement in the dyspnea NIHA class, and this improvement continued and more marked over the extension period of 36 weeks in the patients who received sacubitril valsartan as compared to valsartan. And this was a paramount conclusion. Actually, the findings of this important study suggest that sacubitril valsartan may have beneficial effects in patients with heart failure with preserved ejection fraction, and that further testing of this agent in this patient population may be warranted. The potential benefits of sacubitril valsartan on long-term morbidity and mortality will be evaluated in phase 3 trial, the Paragon heart failure. We'll discuss this trial after that. And this Paragon heart failure study is one of the largest heart failure with preserved ejection fraction trial ever conducted. It included more than 4,800 patients from 43 countries. So it is the largest, actually, it is the largest trials in the patients with heart failure with preserved ejection fraction. And this was the study design of this trial. Let's describe it in a more comprehensive way. It is actually a randomized double-blind active comparator trial testing the hypothesis that sacubitril valsartan compared with valsartan would reduce the composite outcome of total heart failure hospitalization and cardiovascular death. The design was that there was a run-in period. This run-in period included 3 phases. The first phase is screening phase. And the second phase is starting valsartan in a half target dose. The target dose of valsartan is 160 milligram twice daily. So the second phase of the run-in period was a valsartan in a half target dose. Half target dose, 80 milligram twice daily. Then after this phase, they switched to sacubitril valsartan again in a half target dose. The target dose of sacubitril valsartan is 200 milligram twice daily. So half target dose means that 100 milligram twice daily. After the third phase of this run-in period, then they randomize these patients in a 1-to-1 ratio into first group that received sacubitril valsartan in a target dose at 200 milligram twice daily. But if there was any side effects, they have to reduce the dose. And the second group into valsartan in also the target dose of 160 milligram twice daily. These drugs were taken on top of standard of care of these patients, excluding ACE inhibitors and Arps. The primary endpoint of this study was the composite of total heart failure hospitalization and cardiovascular death, both. So it's a composite of heart failure, hospitalization, and cardiovascular death. The secondary endpoints, a very important point, we will mention this later on, is improvement in the dyspnea-NYHA class. This is number one. A change in the Kansas City Cardiomyopathy Questionnaire score, time to first occurrence of worsening renal function, and time to all-cause mortality, all of this with the secondary endpoints. Let's go to this study, and this were the key inclusion and key exclusion criteria. We will not go through all of these points, but we have to know that these patients were having a heart failure with preserved ejection fraction, but some of them were having a heart failure with mid-range ejection fraction, that these patients included have an ejection fraction of 45% or more. So 45 to 50 is a mid-range. More than 50 is a heart failure with preserved ejection fraction. There should be an evidence of structural heart disease in the form of left atrial enlargement or left ventricular hypertrophy, and they assess the natriuretic peptides, either N-terminal pro-BNP in patients in sinus rhythm or in patients with atrial fibrillation. And this was the exclusion criteria, definitely. Exclusion criteria or patient with heart failure with reduced ejection fraction, an ejection fraction of less than 40, or acute decompensated heart failure, or alternative reasons for signs and symptoms of heart failure, for example, patients presenting with acute coronary syndrome, or patients with hypotension or severe hypertension, blood pressure less than 110, or a blood pressure systolic more than 180. These were the key exclusion criteria. The baseline demographic characteristics, there was no significant difference between sacubitril valsartan and valsartan as regards this, all of these demographic characteristics as regards sex, race, region, the baseline left ventricular ejection fraction, the baseline N-terminal pro-BNP in patients in sinus rhythm, or the baseline N-terminal pro-BNP in patients in atrial fibrillation. Also, there was no significant difference between both groups as regards the NYHA class, as regards the body mass index, systolic and diastolic blood pressure. The medical history was a past history of hypertension, diabetes, atrial fibrillation, or hospitalization for heart failure within 9 months. And the previous medications they were using, ACE inhibitors, Arps, diuretics, mineralocorticoid receptor antagonists, beta blockers, or calcium channel blockers, all of these baseline characteristics, there was no significant difference between both groups. The first group of sacubitril valsartan, and the second group is the valsartan alone. And this was the results, the primary endpoints of this trial as regard the composite endpoints of heart failure, hospitalization, and cardiovascular death. If we look to this curve, we can notice that there is a separation of the curves. The separation in favor of the use of sacubitril valsartan as compared to valsartan alone. But if we look to the p-value, the p-value was a borderline significant. So actually, there is a more reduction in the composite endpoints of the total heart failure, hospitalization, and cardiovascular death, but the p-value was a borderline statistically significant. Let's go to everyone separately. Let's go to the heart failure hospitalization. Again, there is a separation of the curves, and this separation of the curves in favor of the use of sacubitril valsartan over valsartan alone. And again, the p-value is a borderline significant. But as regard cardiovascular death, no significant difference at all. As we see very clearly that the curves are going together. No separation at all of the curves. So if we use the composite endpoints of heart failure hospitalization and cardiovascular death, yes, there is separation of the curve. But if we use everyone separately, so there is the benefits more will be the heart failure hospitalization, not the cardiovascular death. And as regards the secondary endpoints, the NYHA class, the Kansas City Cardiomyopathy Score, and Kansas city cardiomyopathy responders and worsening renal function, all-cause mortality. As regards the first 4 points, NIHA class, quality of life, responding to this Kansas City cardiomyopathy questionnaire, worsening renal function, the sacubitril valsartan was superior to valsartan as regard these 4 points. But as regard all-cause mortality, no difference between both. No difference between sacubitril valsartan and valsartan as regard all-cause mortality. As regard the safety endpoints, including low blood pressure, hypotension, elevated serum creatinine, elevated serum potassium, and angineurotic edema. As regard elevated serum creatinine and elevated serum potassium, this was significantly higher in the valsartan group as compared to sacubitril. Sacubitril valsartan was associated with less elevation in serum creatinine and serum potassium. But as regard hypotension and angineurotic edema, this was significantly higher in the sacubitril valsartan group than that in the valsartan group. This was the main results of the Paragon trial. Going to some subgroup sub-analysis of these primary endpoints, including age, including sex. Sorry for this interruption, but it's due to some problems with internet. This is a slide after the last one. The last one was a safety endpoints. And this is what we call subgroup analysis of these patients as regards the primary endpoints. This subgroup analysis including age, sex, race, region, ejection fraction, diabetes, and the renal function using LGFR, and the use of mineralocorticoid receptor antagonists. They found that, and actually I don't have an explanation for this, they found that female patients have more benefited from this sacubitril valsartan than male patients. Patients with ejection fraction below 57 have got more benefit from this sacubitril valsartan than valsartan itself, as compared to those with an ejection fraction of 57 or more. So these were the main findings of this trial. So female patients and an ejection fraction of less than 57. So as regards the ejection fraction, those with an ejection fraction of more than 63, there is no benefit at all of sacubitril valsartan as compared to valsartan. So they recommend to use this sacubitril valsartan in a patient with an ejection fraction of 57 or less. And these are the main groups that got the main benefits. When they tried to combine this sacubitril valsartan in the Paragon heart failure study with the sacubitril valsartan in the Paradigm heart failure study, and this is the main results as regard heart failure hospitalization and death in the Paradigm heart failure, there is definitely significant reduction of this combined endpoint. In the Paragon heart failure also, there is a reduction in these endpoints with a borderline significance. And but if we combine both together, there was a significant reduction of these composite endpoints. As regard mortality, definitely in the Paradigm heart failure, there was a significant reduction in the mortality in the sacubitril valsartan combination as compared to enalapril. But in the Paragon heart failure, there was no significant reduction in mortality with the sacubitril valsartan as compared to valsartan. But if we combine both trials together, we will get a significant reduction in mortality and significant reduction in heart failure hospitalization. All deaths also will be significantly reduced if we combine both trials together, a total heart failure hospitalization and cardiovascular deaths and total heart failure hospitalization. All of this will be significantly reduced if we combine both the paradigm heart failure and the Paragon trial together. To reach to the conclusion, in this large patient-level analysis of two pivotal trials, we observed overall benefit comparing sacubitril valsartan to valsartan alone. And this benefit is mainly due to the heart failure hospitalization. These findings were driven by the benefits in patients with chronic heart failure and an ejection fraction below the normal range. As we said before, an ejection fraction below 57. Those with an ejection fraction of more than 63, no benefit at all. While patients at the highest end of the ejection fraction range, as we said, more than 63, demonstrated lower overall mortality and higher proportional of non-cardiovascular deaths and didn't appear to benefit from sacubitril valsartan compared with the renin-angiotensin system inhibition. In the upper left ventricular ejection fraction range, the benefit was driven primarily by the reduction in heart failure hospitalization, not a reduction in cardiovascular deaths. Women drive benefit to a higher left ventricular ejection fraction than men, as we noticed in the subgroup analysis. This data suggests that the therapeutic effects of sacubitril valsartan compared with the renin-angiotensin inhibitor alone appear to extend to patients with heart failure and mildly reduced ejection fraction. For example, patients between 45 and 50, those patients with a mid-range heart failure, with therapeutic benefits that extended to a higher left ventricular ejection fraction range in women compared with men. And the Paragon heart failure trial was presented in the European Society of Cardiology 2019 and published in the New England Journal of Medicine in October last year. This might take home messages. Trials in heart failure with preserved ejection fraction are increasingly in importance. We need more and more trials as regards this important topic. Again, after all of these trials, we still don't have a clear pathway or a clear algorithm in the management of such patients. Most have shown no improvement except in few subset of patients, for example, women or patients with a heart failure with preserved ejection fraction, LV ejection fraction of less than 57, or in certain comorbidities. We are still waiting for other trials. Actually, we need more and more trials, including those of SGLT2 inhibitors and their effect on outcome in heart failure with preserved ejection fraction patients. Thank you for attention, and I'm ready for any question.
Thank you very much, Professor Nabil, for this comprehensive and elegant presentation about one of the mystery topics, which mysterious topics, which heart failure with preserved ejection fraction. As you said, we still a lot we don't know about the diagnosis. We still a lot we don't know about the management, and some of the researches is going on to help us for managing this challenging problem. Actually, Professor Nabil, I have one of the maybe a practical question about the diagnosis and the management of the heart failure with preserved ejection fraction based on the evidence. Do you think that the diagnosis, most evidence is based on the clinical presentation and the clinical history of the patient, or the biomarkers, or the diastology and the diastolic function of the on echocardiography? This is as regard to the point of the diagnosis. As regard the point of management, Do you think that we have be more interested with managing the heart rate and the dysrhythmia problems in such a condition, heart failure with preserved ejection fraction, or dealing with the coronary artery disease even by revascularization to correct the HFpEF, or adding a new drug just like the valsartan cyclopetril, which has, as you shown us in the Paragon heart failure, has some benefit, especially in the heart failure with mid-range ejection fraction and those with heart failure with preserved ejection fraction and ejection fraction less than 63. What do you think about the diagnosis, the management, and the use of the cyclopetril valsartan in practice, when practically in heart failure with preserved ejection fraction?
Thank you, Dr. Syed, for these very important points and these very important questions. Number one, as regards the diagnosis, definitely we follow the guidelines. Patients with heart failure with preserved ejection fraction should have symptoms. Number one, should have symptoms of heart failure, dyspnea or apnea or limb edema, all of this. Plus or minus signs of heart failure, but symptoms of heart failure, this is number one. Number two, they should have some structural abnormalities by echocardiography in the form of finding of evidence of diastolic dysfunction as regards the EA ratio or the E over E prime, or the presence of left atrial enlargement, as we mentioned before. In addition to the plasma level assessment of internal proBNP, and this should be high. All of these are the criteria for diagnosis of heart failure patients with preserved ejection fraction. Symptoms, echocardiographic findings, and the detection or assessment of the level of internal proBNP. How to manage such patients? Usually, patients with heart failure with preserved ejection fraction have other comorbid conditions, as you mentioned, Dr. Syed. For example, these patients may have, for example, atrial fibrillation. And it's very important to manage atrial fibrillation in such patients very properly, because management of atrial fibrillation in such patients will improve the symptoms and signs and will improve the outcome. Patients with coronary artery disease should be managed correctly and should be managed properly. Also, patients with COPD, a lot of comorbid conditions that should be treated. And all of these comorbid conditions may lead to this heart failure with preserved ejection fraction. After you manage all of these comorbid conditions, you can go to, for example, hypertension. Management of hypertension in such patients is very important. Then, after you address all of these points, you can go and use the sacubitril valsartan in a such patient, but first treat the associated comorbidities and then add the sacubitril valsartan in such patients.
Thank you, Professor Nabil, for the clarification for the points I asked. And if there is any questions from the audiences, we check. Okay, no questions yet. Do you think, Professor Nabil, that in the future, based on that the heart failure is not only the myocardial sector of this syndrome, but also the hormonal sector of the syndrome? As you all know that there is activation of the RAS system in the heart failure patients, and that's why there's maybe a success for rate of hospitalizations for those patients using sacubitril valsartan. So that's why I'm still thinking that there is a way for success for sacubitril valsartan even in patients with heart failure or preserved ejection fraction, because of the activation of the hormonal axis and its all deleterious effect in heart failure patient. Do you think that the upcoming trials will show us more success than the Paragon heart failure?
Actually, we have to wait. I don't have a clear answer for this, because the Paragon heart failure patient with preserved ejection fraction was a large study and included 4,800 patients, the big number of patients, and the results, yes, it was in favor of sacubitril valsartan combination, but the difference was not statistically significant. But the comparison between sacubitril valsartan and valsartan, which is also good for the management of such patients. I think if we compare sacubitril valsartan with placebo, those who are not using any Arps or any ACE, I think the results will be different. The results will be much more significant as regard reduction in morbidity, heart failure, hospitalization, and even a reduction in mortality. I think these results of this Paragon trial is due to the use of other arm of valsartan, which is also a very good drug. It's a good drug, and this is another good drug. So you are comparing two good drugs with each other. If we compare one good drug like sacubitril valsartan with no drugs, placebo, or placebo, I think the difference will be statistically significant. And this point was one of the criticisms of the Paragon. The Paragon was criticized because the other group was using a good drug, which is valsartan.
Yes.
So in the future, if they have a trial comparing sacubitril valsartan combination with placebo only, yes, we will have a much more significant results in favor of use of this drug.
Actually, we have to thank Professor Nabil Farag for this very elegant, very interesting, very important evidence for heart failure with preserved ejection fraction. I think Professor Nabil covered all of our questions in our minds, and I think we have now to be ready for the coming presentation, which is also very interesting, the diagnosis and pitfalls by Professor Mohammed Salim. Thank you again, Professor Nabil, to be with us in this HFpEF night. We have a great pleasure to have you with us tonight. Thank you, Professor Nabil. Thank you. Now we are coming to the second part of our HFpEF night. Very interesting also, very important. One of the mysterious sectors of the HFpEF, the diagnosis and the pitfalls. And I think we have one of the elegant cardiologists all over Egypt who will uncover for us some of the mysteries and the mysterious points of the HFpEF. Professor Mohammed Salim, I have the pleasure to introduce them. He is my colleague. He is one of the eminent cardiologists in Egypt. I have the pleasure to introduce him. Professor Salim.
Thank you, Professor Sayed. It's my pleasure to be with you today, this night, and Dr. Nabil Farag. I think now I'm sorry also for any inconvenience because I'm supposed to start, but for some urgent beyond my hand commitment, I have to present my presentation at this time. Thank you again, and I will start by my presentation is about the diagnosis and the pitfalls about the heart failure with preserved ejection fraction. As you know from the most recent European guidelines, the diagnosis of heart failure with preserved ejection fraction requires the presence of symptoms and signs of heart failure, together with estimation of ejection fraction above or equals to 50%, and elevated levels of natriuretic peptides, together with at least one additional criterion, either structural abnormality in the form of left ventricular hypertrophy, for example, or increased in the left atrium volume index or area, or other functional diastolic impairment, either assessed by the tissue Doppler or by the ratio between the E to E prime. The pitfall number one in the heart failure with preserved ejection fraction is the value of the ejection fraction as a predictor of sudden death. All of you know very well that ejection fraction is very important and very strong prognostic marker for estimation or predicting the sudden death. This diagram or plot showed the lower the ejection fraction, coming from the lower right corner of the curve to the upper left corner, you will see tremendous and progressive increase in mortality, which will be very steep if the ejection fraction becomes less than 20%. However, this linear and sometimes exponential relationship may be not present if the ejection fraction is exceeding 45%. As you see here, the curve will be flat. So if the ejection fraction approaching the normal value of 50% or more, it gradually loses its prognostic value as a predictor of sudden cardiac death. Not only that, but we will find that there are other risk modifiers, like diabetes, for example. If you see this curve, the altered relationship between the left ejection fraction and death or heart failure in patients with diabetes, we can see that there is an equivalent risk for death or heart failure in a diabetic patient with ejection fraction of 40% equals to the risk exactly of a non-diabetic patient with an ejection fraction of 25%. So presence of diabetes can lead to 15% equivalent difference between the ejection fraction as a predictor of mortality and other outcomes in heart failure. Another example, or similar to diabetes, is the presence of CKD or chronic kidney disease, which is well recognized as a comorbidity contributing to the increased risk for cardiovascular outcomes in patients with heart failure. We have data from many trials with thousands of patients followed over more than 10 years have shown a significant interaction between the estimated GFR and left ventricular ejection fraction, with each of these parameters becoming relatively more important with lower values of the other. The combination of LV systolic dysfunction and a chronic kidney disease was associated with two-fold 10-year mortality risk. And so we can say that the ejection fraction is not the only player in the even in the heart failure with the reduced ejection fraction, and it decrease its prognostic value in patients with HFpEF or heart failure with preserved ejection fraction. Not only that, the pitfalls in measurement of ejection fraction itself by echocardiography. You know that left ventricular ejection fraction measured by echocardiography is not measured directly. It is measured indirectly. And it was calculated, or it is calculated from estimation of the LV volume. While, on the other hand, the tomographic techniques such as MRI or CT calculate ventricular volumes by summating multiple equally spaced slices in end diastole or end systole, requiring no geometric assumptions. In echo, we have to make some geometric assumption and decrease accuracy of direct measurement of left ventricular ejection fraction, because we have to infer about the ventricular shape in order to estimate a three-dimensional volume from a two-dimensional image. Also, echocardiographic is not a tomographic technique with various technical limitations. Some of these limitations partly inherent to echocardiography as non-tomographic technique, and it hampers the calculated ejection fraction values, poor image quality, anatomy difficult to scan, often leading to foreshortened ventricles. As you see here, if I will cut through the long axis of the left ventricle in this way, exactly halfway between the lateral wall and the septal wall, I can estimate a volume of 74 ml. With any minor inclination of the cutting at the apical four-chamber view, as you see here, it's the same patient exactly, the volume will be reduced to 52 milliliters. In addition, the tedious and time-consuming process of manual delineation of the endocardium with boundary continuity unfortunately often out of plane, being prone to inter and intra-observer variability. And even The novel semi-automated delineation applications dealing with these issues, particularly lacking standardization and reproducibility between different machines and different vendors. You know that left ventricular ejection fraction is a volume-driven index, rely on geometric assumption, and is extremely load-dependent. These limitations lead to substantial loss of reproducibility, and even repeated measures of ejection fraction in the same patient over a brief time period can result in 5 to 7 point variability, even more than this. And the measurement of left ventricular ejection fraction may be influenced by changes in the LV geometry and not necessarily corresponding to true LV contractility. For example, in athletes with an enlarged LV and excellent LV contractility, this increase in the cavity marginally will lower the left ventricular ejection fraction values may be obtained. Also, in a severe form of LVH, supranormal left ventricular ejection fraction values are often measured. Also, in dysynchronous ventricles, such as in left bundle branch block, the largest LV volume is not necessarily corresponding to the end diastolic volume, which may impede the performed left ventricular ejection fraction measure. So, the problem with ejection fraction in HFpEF or heart failure with preserved ejection fraction tells only part of the story. It is not the only player. We have other risk modifiers. Second, prognostic significance much poorer in heart failure with preserved ejection fraction, as I showed you the diagram of decreasing the prognostic ability of ejection fraction if it will be more than 45%. Not always so easy to measure. Very difficult sometimes in some patients with anatomical difficulty and suboptimal image quality. This will lead to poor reproducibility and extreme variability up to 7 points plus or minus in most labs. This is the ejection fraction. So in HFpEF, we have to have alternatives to ejection fraction. What are these alternatives to ejection fraction? Here we have what's called myocardial deformation. You know that myocardial fiber architecture of the LV consists of endocardial and epicardial layers composed of longitudinal fibers and mid-myocardial layers formed mainly by what's called circumferential fibers. In systole, the shortening of the longitudinal fibers causes displacement of the LV basal plane towards the more stationary apex, while the shortening of the circumferential fibers will cause inward movement of the LV towards the center of the LV cavity with corresponding increase in the radial thickening of the LV. This deformation in both of these planes, longitudinal, circumferential, associated with transverse or radial thickness, reduce the LV volume during systole. Then, if measured by volumetric technique, ejection fraction is the principal one of them, reflects function of both longitudinal and some circumferential fibers together. It cannot differentiate or distinguish between both of them. How can I distinguish? Because HFpEF is not only diastolic dysfunction. It is not equal to diastolic dysfunction. More than 60 to 70% of patients in the early course of HFpEF showed subtle systolic dysfunction in the form of impairment of these longitudinal fibers. And advances in the echo techniques like speckle tracking and tissue Doppler can identify a speckle and can be tracked in 3-dimensional. And speckle tracking analyze the motion of the coherent speckle to assess the myocardial deformation. And for this speckle tracking, I can obtain what's called strain and strain rate. The strain is the difference between the lengths of longitudinal deformation or longitudinal fibers or circumferential fibers between the resting state and the contracting state or during systole. In HFpEF, there is an impairment at the beginning of the longitudinal fibers, which can be shown here from the apical four-chamber view, when I can obtain the strain or the difference between the length of longitudinal fibers during the resting state and the systole. So I will here I can gain a negative value, and if this negative value is measured against time, we will gain what's called strain rate. Also, I can assess the circumferential fiber deformation or shortening in left parasternal short axis and long axis view. So the value of the longitudinal strain and circumferential strain will be by negative, while the radial thickening will be by positive. This is the strain and the strain rate, which can be measured by speckle tracking and are very important alternatives to the ejection fraction in case of HFpEF. Not only that, but also both of them, the longitudinal strain and the strain rates and the circumferential strain and strain rates are associated with or correlated with the all outcomes of the heart failure in HFpEF, all-cause mortality, cardiovascular death, or repeated hospitalization. Here is the comparison between the normal person and HFpEF patient. You see here the ejection fraction almost the same. Here is 65, here is 63. But if you will come here to the longitudinal strain in this patient with normal, both longitudinal deformation and circumferential deformation, we can reach a significant shortening of the fibers during systole, reaching a negative value of 21. In comparison here to a patient of HFpEF, in which the strain will be only minus 13, means that the shortening of the fibers here is significantly impaired, although the volumetric index of the contractility, which is the ejection fraction, is almost the same. Also, if we will come here to the other parameters, this is a systolic indicator of systolic function. If we will come to the systolic index, like the velocity of the early mitral annulus, we will find that the velocity will be decreased in HFpEF patients, and also the systolic wave velocity will be markedly decreased. About the E over E prime, which reflects the left ventricular end diastolic pressure, will be increased in patients with HFpEF in comparison to patients with normal diastolic functions. As you see here, the strain or the longitudinal strain and circumferential strain, if we will compare the control and also we can classify patients heart failure with preserved ejection fraction into three tertiles: ejection fraction less than 50%, between 50 to 51, and above 55%, we will find that there is a statistically significant difference in each subclass of these patients, reflecting the marked sensitivity and specificity of this strain and strain rate in distinguishing between the HFpEF and the normal person. Also here, if we will come to the normal subject in comparison to hypertension with diastolic dysfunction, we will find the strain will be the same, while in patients with HFpEF, we will find significant reduction of the strain, longitudinal strain and circumferential strain in patients with HFpEF, while here, after severe systolic impairment, we will find reduction of the ejection fraction, and this is the patient with HFrEF or heart failure with reduced ejection fraction. Also, global longitudinal strain and outcomes was found to be strongly correlated in many trials. One of them is TopCat study, in which the decrease in the global longitudinal strain is associated with increase in the primary endpoint of cardiovascular mortality and recurrent heart failure hospitalization. If we will come here to see the statistical power of different predictors of outcome in HFpEF, we will find here, compared to age, to E over E prime, LV mass, left atrial volume, left ventricular ejection fraction, we can find in either univariate or multivariate analysis, the statistical power of global longitudinal strain is very significant in patients with HFpEF. So global longitudinal strain now replacing ejection fraction even in the guidelines to express or can detect early systolic subtle changes, and it is now considered to be class 2A in the guidelines, in which other techniques, including systolic tissue Doppler velocity and deformation indices like strain and strain rate, should be considered in transthoracic echo protocol in subjects at risk of developing heart failure in order to identify myocardial dysfunction and systolic dysfunction at the preclinical stage at which ejection fraction is still normal. Now we will come to the second salient features of heart failure with preserved ejection fraction, which is the increase in the biomarkers. You know that with myocardial stretch, there is activation of this pathway, more expression of BNP gene, which will eventually lead to increase in these natriuretic peptides. One of them is an active metabolite, which is the BNP, and one of them is biologically inactive metabolite, which is the N-terminal pro-BNP. And active metabolite BNP will counteract the renin-angiotensin system, causing natriuresis and diuresis, and help as a compensatory mechanism that will decrease the volume overload and increase the sodium excretion. Here is the different natriuretic peptides with different half-life, and you can see that many other factors can falsely decrease or increase the levels of these natriuretic peptides on the same level of functional capacity and on the same level of the ejection fraction, like the rate of renal excretion will markedly determine the level of both BNP and N-terminal pro-BNP. For an ideal biomarker, we should diagnose HFpEF accurately at its early stage of the disease, forecast the likelihood of disease complication, or what's called the prognostic value, and also it can help to guide the management decisions. Natriuretic peptide biomarkers have a high negative predictive value for the diagnosis of heart failure, both in acute and non-acute settings, and are often used to exclude practically the diagnosis of heart failure in patients with unexplained dyspnea. However, in patients with HFpEF, up to 30% of individuals have normal BNP at rest, and falsely normal BNP can occur in the setting, for example, of obesity, and obesity is one of the very common associated criterion in patients with HFpEF. An elevated natriuretic peptide level is not specific also for heart failure, with other causes as chronic kidney disease, atrial fibrillation, which is present almost in about 2/3 of patients with HFpEF, in pulmonary hypertension, which is present in almost 20 to 25% of patients with HFpEF. These comorbidities are common in HFpEF, limiting the diagnostic sensitivity and specificity of natriuretic peptides. An elevated natriuretic peptide level carries significant prognostic implications. For example, in asymptomatic individuals, elevated BNP level will increase the risk of developing HFpEF over a median follow-up of 12 years. Similarly, for outpatients with stable chronic HFpEF, elevated BNP level predicted the composite outcome of mortality of heart failure and heart failure hospitalization over a follow-up of 1.5 years. In these studies, natriuretic peptide levels were significantly lower in patients with HFpEF than those with HFrEF of similar functional class of New York Heart Association classification. However, in both cases, prognosis was independently associated with elevated natriuretic peptide level and not left ventricular ejection fraction. About the adjustment of the medical management in chronic HFpEF patients, serial monitoring of NT-proBNP did not improve the hospitalization-free survival over 18 months. There is another marker mentioned in the guidelines called mid-regional pro-atrial natriuretic peptide, which is elevated especially in patients with HFpEF. However, this new biomarker has not demonstrated superior over more established natriuretic peptide. Also, there are, HFpEF is a disease of comorbidities, which will create a state of low-grade pro-inflammatory condition. So other biomarkers are activated in HFpEF, like TNF-alpha, interleukin-6, and others. Also, there are other markers that will measure the degree of myocardial fibrosis and remodeling, like soluble ST2, galactin-3, metallic metalloproteinase, inhibitors of metallic metalloproteinase, procollagen type 3 N-terminal propeptide, and other biomarkers. So the natriuretic peptides are not the only biomarkers that will be increased in HFpEF patients, but still we have many markers either to reflect the chronic inflammatory condition or reflecting the degree of myocardial fibrosis and abnormal unfavorable remodeling. And some of these biomarkers will also be correlated with recurrent hospitalization and primary endpoints of cardiovascular mortality. And still, natriuretic peptides occupy very important position in the diagnosis of HFpEF. It is one of the 3 domains mentioned for the criteria in the most recent algorithm for diagnosis of HFpEF, in which we classify either functional alteration or morphological alteration or biomarkers into major criteria or minor criteria, and we will give major criteria 2 points and minor criteria 1 point. Here in biomarkers, because atrial fibrillation will markedly increase these BNP and pro-BNP, so the cutoff values may be 3 times in patients with atrial fibrillation in comparison to patients in normal sinus rhythm. Now we will go for the problem of atrial fibrillation. Heart failure with preserved ejection fraction and atrial fibrillation could be considered as bad twins, or what's called vicious twins. They are present together and can overlap each other. HFpEF and atrial fibrillation are both of them age-related conditions that are increasing in prevalence, commonly coexist and share clinical similar features. Epidemiological studies highlight the close and complex links between HFpEF and atrial fibrillation. The shared risk factors, the high AF occurrence in the natural history of HFpEF, and the independent contribution of each condition to poor outcome. Diagnosis of HFpEF in the setting of AF is very challenging because of overlapping of symptoms. AF is associated with changes also of echocardiographic parameters and circulating natriuretic peptides that confound HFpEF diagnosis. Symptomatic improvement with diuretic therapy support the presence of HFpEF in patients with concomitant AF, and also the rate control or rhythm control of patients with AF with symptomatic improvement will support the AF as the contributing driving pathophysiological mechanism in those patients. As you see here, both of them sharing many comorbidities, either cardiovascular comorbidities or other, like obesity, obstructive sleep apnea, physical deconditioning, elderly, both of them disease of the elderly, of course, coronary artery disease, chronic kidney disease, and COPD. As you see here, all these comorbidities are present with variable degree in both AF and HFpEF. Also, there are very significant overlap of symptoms, and also if you see the investigation, we can find left atrial enlargement in both HFpEF and the atrial fibrillation. We can see increased natriuretic peptides in both of them, and hence, as I mentioned before, the cutoff value of natriuretic peptides may be 3 times in AF more than in sinus rhythm. Symptom overlap in HFpEF and AF, like dyspnea, like fatigue and exercise intolerance, like palpitations and pre-syncope are present in both HFpEF and in atrial fibrillation. Also, atrial fibrillation in heart failure with preserved ejection fraction is associated with poor exercise, more decrease in exercise capacity, more increase in the left ventricular filling pressure, more increase in natriuretic peptides, and increase in left atrial volume index. Here is the natriuretic peptides entry criteria in HFpEF trials, and we will see the marked difference in case of AF in comparison to normal sinus rhythm. Now we will come to, we have to formulate scores and algorithms that will incorporate many array of criteria into numbers, so I can diagnose HFpEF. Here is this very important validated score, which is called H2f score, in which there are 6 variables. H for heavy or body mass index more than 30 kilogram per square meter, which is giving 2 points. Hypertension or history of antihypertensive medications will be given 1 point. The most important of them, which is F or fibrillation, paroxysmal or persistent atrial fibrillation, will be given 3 points. This is the most important parameter in this score for diagnosis of HFpEF. Pulmonary hypertension, defined as Doppler echocardiographic estimation of pulmonary artery systolic pressure more than 35 millimeter mercury, will be given 1 point, and age above 60 years of age, 1 point. Filling pressure increased as reflected by increase in the E wave over E prime wave more than 9 ratio, will be given 1. So the maximum score will be 9, and if the score is 9 in such patient, the probability of heart failure with preserved ejection fraction is more than 95%. Here is the intermediate probability, in which the score is between 4 to 6, and less than 4, it is low probability of the presence of HFpEF. This score is validated and it is correlated with the primary outcome in patients with HFpEF based on both univariate and multivariate analysis. If you look here for these 6 variables, we can see for the first time the gender is out, or the sex difference. It was said that the HFpEF is more common in females, but here it is not included. Natriuretic peptides is not included, and the left atrial volume index is not included in this score. So we have another most recent algorithm for heart failure with preserved ejection fraction, and the key element for this HFpEF diagnostic algorithm, it is a stepwise diagnostic approach, starting from initial screening or initial clinical assessment up to more specialized and sophisticated tests, up to invasive hemodynamic measurements. The diagnosis of HFpEF is not always straightforward, so the integration of distinct parameters from complementary diagnostic domains into a new diagnostic score is highly recommended in this algorithm. In patients with an inconclusive score, definitive diagnosis or exclusion will require invasive hemodynamics and or non-invasive or invasive exercise stress test. Underlying pathophysiological alteration like chronotropic incompetence, reduced LV compliance, and specific etiology like amyloidosis, for example, have to be considered, and the precise diagnosis is increasingly important since new targeted therapy, like also in amyloidosis, like the tafamidis, can make a great benefit in those patients. So it is very important in some patients to reach to a precise diagnosis. This is the algorithm, 4 stages: E for pre-test assessment or initial workup, E for the echocardiographic and natriuretic peptide, and this is the second step in which the patient will be given a score, and the third step is the advanced workup, functional testing, either diastolic stress test or invasive hemodynamic measurement, and the last one, F2, which is the etiological workup or final etiology. That could be including MRI, cardiac or non-cardiac biopsy, scintigraphy, genetic test, or more advanced lab diagnosis. This is the step one, consists of a patient with high probability of heart failure, clinical assessment, standard diagnostic test, pre-test results are suggestive of HFpEF. Okay, go ahead and go for the second step, in which the HFpEF score either low, intermediate, or high. A total score of 5 points or more is considered to be diagnostic of HFpEF, while a score of less than 1 point is considered to make diagnosis of HFpEF is very unlikely and to mandate investigations and search for alternative causes. Patients with an intermediate score between 2 to 4 points, we have to go for step 3. In step 2, as I mentioned before, we have 3 domains: functional, morphological biomarkers, and biomarkers either in sinus rhythm or AF. And in each domain, we have major criteria or minor criterion. Major criteria will be given 2 points. Minor criteria will be given 1 point. And if points more than 5, it is a definitive diagnosis of HFpEF. Functional, like the septal E prime velocity, lateral E prime velocity, ratio of E to E prime, pulmonary artery systolic pressure, and if this number is less, this is the minor criteria. The same in the second domain, which is the morphological changes in the form of left atrial volume index or left ventricular mass index in female or female, together with the relative wall thickness. And if this number is less or below these cut-off points, it will be a minor criteria. And here is the biomarkers either in sinus rhythm or in patients with AF. And again, in patients with AF, the cut-off may be 3 times the normal level in sinus rhythm. If the score between 2 to 4 points, I have to go to step 3. Step 3 consists of A and B. A is the advanced heart failure with preserved ejection fraction workup in the form of echo stress test. And during echo, I can assess the average of E over E prime if it is more than 15, together with tricuspid regurg velocity more than 3.4. So I will give another 2 points, will be added again to the previous score. So if the patient from the previous step acquired 3 points, and here by echo stress test given 2 points, so the definitive diagnosis of HFpEF. If these criteria are not present, so I have to perform what's called invasive hemodynamic measurements, left and right heart catheterization. Invasive hemodynamic measurement addressed to assess the left ventricular end-diastolic pressure and pulmonary capillary wedge pressure, either at rest or at exercise. If it will exceed these numbers and cut-off points, so the diagnosis of HFpEF will be established. The final step in this algorithm is the etiological workup, will consist of either stress test and assessment of inadequate blood pressure response to exercise, chronotropic incompetence, ischemia, and in each step we can make intervention to assist in the proper management of patients with HFpEF, like blood pressure control, management of chronotropic incompetence, ischemia workup, and then lastly I have to go for CMR or MRI for diagnosis of specific cardiomyopathy like infiltrative cardiomyopathy or amyloidosis or other rare hereditary infiltrative disease. So my take-home message for the diagnosis and pitfalls of patients with heart failure with preserved ejection fraction: the diagnosis of such clinical entities is still challenging. Understanding of the pathophysiology of HFpEF has advanced. Diagnostic options have evolved, and this novel information needs to be integrated into a new comprehensive diagnostic algorithm for suspected HFpEF patients. Echocardiography includes multiple non-conventional measurements like myocardial deformation imaging using speckle tracking that should be done and are very important for diagnosis of HFpEF, and now it is considered to be class 2A in the guidelines and it can detect the early subtle systolic changes in patients with HFpEF. Biomarkers are important, but have many diagnostic limitations in HFpEF, with questions about the sensitivity and specificity. Atrial fibrillation, which is considered to be the bad twin or vicious twin of HFpEF patient, is very common association, could interfere with the diagnosis in some cases due to symptoms overlap. And thank you for your attention.
Thank you, Professor Salim, as usual. Very elegant, comprehensive, and actually up-to-date, really up-to-date data, because if the audience would like to know that the scores Professor Salim presented in his presentation is just published few weeks ago. It's about 4 or 5 weeks ago in the Journal of American College of Cardiology. And actually, those are the first scores ever in diagnosis of HFpEF. One of them, which is the HFpEF, is in 2019, but the H2fPEF is in 2020, just in June. And in this very interesting paper, they also declare, Professor Salim, that those scores are very important, of course, for diagnosis, but also for prognosis, because those with higher scores have also higher rate of hospitalization and also higher rate of mortality for those who have higher scores. As you shown us, Dr. Salim, that the management of HFpEF is not an easy task, and we should to be multidisciplinary. Do you think that it is the time, or the time is coming to change the shape of the echocardiography report? Because as we all know, the shape of the and the format and the construction and the data inside the echocardiography is almost the same everywhere, especially here in Egypt. Do you think it is a time to change this format, including the deformation rate, longitudinal, circumferential, the more diastolic indices to be studied and to be reported for the sake of diagnosing better and also detecting the prognosis for those patients with HFpEF? Do you think?
Yes, Professor Said, it's a very important point. As you see in the guidelines, it is considered to be now class 2A.
Yes.
So it should be done. Ejection fraction will, as you see, reproducibility of ejection fraction is very poor. I can make ejection fraction today, and I can write 50%, another person 45%, another one 55%. So we have to reach to a more precise and more objective indices, which will reflect both systolic and diastolic dysfunction. And there's still up to now misunderstanding about HFpEF as being only diastolic abnormality, but as you see here in the deformation indices, it is purely systolic. It's purely systolic, and you see that the longitudinal strain will be affected early and will be compensated by circumferential shortening, and then both of them will be affected at a later stage. So I think it should be incorporated in each report of our daily practice of echo for these indices of deformation. But the main limitation, I think, that it is a little bit time consuming, and it needs a good experience, and it needs to take some time as a learning curve for a person to be expert in such measurements.
We have here some questions from the audience. Dr. Nabil is still with us, or he left already? Mu'taz? Left, okay.
No.
So,
still.
لا موجود دكتور نبيل موجود.
طبعا هو كان behind the mask بس.
Yes.
طيب.
I'm working from my clinic.
Yes, there is an important question for Dr. Nabil here. Is He said, I am a bit confused with the comparison of Paradigm and the Paragon trial. This is a question that the audience, one of the audience here, can you clarify for him again, please, this point?
In the Paramount trial, the primary endpoint was a reduction in N-terminal proPNP. This is a neurohormonal assay, actually. In addition to indirect evidence of improvement of LV diastolic dysfunction as regard the left atrial size and improvement in the dyspnea-NIHA class. These were the primary and secondary endpoint of the Paramount. The number of patients in the Paramount was only 300 patients. In the Paragon, the number of patients was 4,800 and more. And the primary endpoint of the Paragon was a composite endpoints of heart failure, hospitalization, and cardiovascular deaths. This was not the primary endpoints in the Paramount study. And these were the main difference in the Paramount and the Paragon study. This, if he wants to know the difference, the main difference.
Okay. Another question, Dr. Nabil. Using ARNI with our patients in insured service, some patients show great improvement and some not improved. What do you think the cause behind the non-responders?
I think for which patients you are using this ARNI. Number one, in patients with heart failure with reduced ejection fraction or in patients with severe heart failure, those are the patients who benefit more with this combination, with sacubitril valsartan combination. In patients with heart failure with normal ejection fraction and diastolic dysfunction, or what we call heart failure with preserved ejection fraction, especially if the ejection fraction is more than 60 or 63, these are the patients who were not benefited in the clinical trials. So according to the patient type, according to the patient profile, you are using this drug. Up till now, I think the ARNI or the sacubitril valsartan are most beneficial in patients with heart failure with reduced ejection fraction or in patients with heart failure with severe or very low ejection fraction.
A question to Professor Selim here. I think it is about the diastolic indices in the diagnosis of HFpEF. He said here that not every E over E ratio less than 1 is designated diastolic or diagnosed as diastolic dysfunction. I think it is right. What do you think about the other diastolic indices which is reliable, which are reliable for diagnosing the diastolic impairment, Professor Selim?
Okay, as I mentioned and I showed you in the most recent algorithm for HFpEF, we will never depend upon only one criteria. We have either functional, morphological, or biomarker. And in each one of these domains, we have major criteria and minor criteria with some cut-off values because it is variable. The sensitivity and specificity of each one is not, of course, 100%. It ranges between 80 to 90%. We will depend on diastolic velocity of the mitral annulus, either septal or lateral. We will depend upon the E to E prime, which will reflect the left ventricular end diastolic pressure. We will depend upon the tricuspid regurg velocity. So we will never take only one parameter. We are taking many parameters together and collecting our data to reach a summation of points to reach to definite score.
Finally, speaking about the experience of two of the eminent cardiologists in Egypt, Professor Selim and Professor Nabil, I'd like to take in 2 or 3 statements. What is the cornerstone you use practically in your patients, Professor Nabil, in diagnosing, in managing, and in following up your patient with HFpEF? Professor Nabil is still with us, yes.
Yes. As regard the diagnosis in practice, you are talking about practical.
Yes.
I'm not expert in echocardiography, but I think echocardiography is very important in diagnosing patients with heart failure with preserved ejection fraction. And now we have the tissue Doppler. We have a lot of new modalities that can diagnose accurately.
Do you use the biomarkers?
No, actually, no. I'm not using biomarkers. I'm depending mainly on the symptoms and signs of heart failure, and as well as structural abnormalities that found by echocardiography, like left atrial enlargement, Doppler mitral flow, or tissue Doppler to assess the diastolic function of the patient. This as regard the diagnosis. As regard management of patient with heart failure with preserved ejection fraction, as we said before, we have to treat the comorbid conditions, because most patients with heart failure with preserved ejection fraction are due to other comorbidities, like Dr. Salim mentioned. For example, atrial fibrillation, patient with hypertension, patient with COPD, patient with coronary artery disease. All of these elderly patients. Age is an important factor for heart failure with preserved ejection fraction. All of these factors are very important to be tackled and to be treated properly. First, for patients with heart failure with preserved ejection fraction, before starting even these new drugs.
Okay. Dr. Salim?
Thank you, Dr. Sayed. I agree with Dr. Nabil that the HFpEF is a clinical syndrome mainly of the elder. This is number one, and can be defined by the presence of comorbidities. And these comorbidities really will lead to what's called chronic inflammatory state. And this chronic inflammatory state will recruit inflammatory markers, and the inflammatory cells will increase in the myocardial fibrosis and remodeling. And here is the pathological mechanism, and the compensatory mechanism is completely different than patients with HFrEF. And in my opinion, this is why most of the trials using the RAS inhibitors and the beta blockers failed to show clear benefit of these drugs in this a little bit perplexing or confusing clinical syndrome. To be honest with you, 2 years before I started to change my practice in diagnosing HFpEF, and I will depend now on the scores. As you see, the presence of body mass index above 30, the presence of hypertension, the presence of atrial fibrillation, the presence of pulmonary hypertension in a patients with symptoms of heart failure and left ventricular ejection fraction normal. So I have to consider the presence of HFpEF, and I will concentrate, as Dr. Nabil said, on the management of these comorbidities that will change the outcome, and it can decrease the symptoms of patients with HFpEF.
Thank you, dear colleagues and professors. I think after this HFpEF knife, we uncover a lot of the mysterious points in this challenging problem, which is the HFpEF, which, as Professor Nabil and Professor Salim mentioned to us, by evidence and by practice and by the guidelines, we have to have a clear clinical presentation, and we have to have some scores which is recently published, and it depends upon a clinical points and some data which easy to be applied in these scores and easy to be picked up during the patient visit. I think by doing this, we can reach the diagnosis of HFpEF, and also by doing a proper echocardiography will help us for diagnosing the HFpEF by expert in the echocardiography. I think it is now a must. Also, the cornerstone in the treatment here, as Professor Nabil and Professor Salim mentioned to us, evidence-based, that the management of the comorbidities, the dysrhythmia and the hypertension is one of the major pathways in treating the HFpEF. Also, the weight reduction, I think it is a very important step in managing the HFpEF, and it comes after the symptomatology treatment, and then the treatment with the recent drugs may have an effect, especially for those patients not responding to the conventional method like the ARNI. I think at the end, we have a fantastic HFpEF night with a lot of data, with a lot of uncovering for the mysterious points in the HFpEF. Thank you again, Professor Nabil Farag. Thank you again, Professor Mohammed Salim. Thank you, Professor Ahmed Shawqi, for organizing this fantastic program. And we would like also to thank our president of EAVA, Professor Ashraf Reda, for giving us the support for this program. And thank you also, Novartis, for supporting this important program, and the fantastic organization also should be appreciated by ICOM. And thank you for listening to us and attending with us this important webinar, and have a good night.
Thank you, Dr.